I am Mary Lloyd Ireland from the University of Kentucky, orthopedic surgeon. This presentation is on ankle injuries and gait. The ankle is a modified hinge joint. The bony configuration makes it inherently stable. In carpentry terms, it is like a mortise or a drawer going into a chest of drawers. It's a circular pretzel. Ligamentously, the lateral ligaments are most commonly injured. We are seeing more syndesmotic injuries or high ankle sprains, and if the injury is an eversion, the deltoid can be injured medially. This anatomic cadaver specimen shows the anterior talofibular ligament where the clamp is. This is the most commonly injured ligament in an ankle sprain that occurs in plantar flexion inversion. You can also see the peroneal tendons in the lower left, the Peroneus brevis and longus, that are well seated in the fibular groove. In a more severe ankle injury, the calcaneofibular ligament will be injured, which runs from here to here. So the lateral ligaments schematically, again, anterior talofibular ligament, calcaneofibular ligament, and the posterior talofibular ligament. The classic mechanism, Netter's drawing, shows injury mid-substance to two ligaments of the calcaneofibular posteriorly and talofibular anteriorly. Palpating those ligaments is very easy to do in an acute situation, and the individual hurts laterally. Swelling is what limits how quickly the recovery occurs after an ankle sprain. This is an example of a high ankle sprain. This is a dorsiflexion mechanism injury. Pain is over the medial deltoid ligament, and you can see the ecchymosis here over the syndesmotic ligament, and also the ecchymosis which has occurred because of a lateral ankle sprain. So this is a severe ankle sprain that is both high, lateral, and medial. We would have concerns that this could be an unstable mortise situation, a Maisonneuve type injury, but in this patient there were no fractures or significant medial instability. Again, the typical inversion, plantar flexed injury that occurs. In the middle, you can see how much ecchymosis there is. We do talar tilt views to assess a difference in the angle of the talus to the tibia. Greater than 10 degrees indicates significant instability, which may require lateral ankle reconstructions, which typically are anatomic and done in a Brostrom method. The classic common lateral ankle sprain, plantar flexion inversion. You can see the amount of ecchymosis in this individual. We do clinical exam and then also Xrays where there is a talar tilt measuring the angle between the talus and the tibia. In neutral flexion and plantar flexion, greater than 10 degrees indicates significant instability that may require lateral ankle reconstruction. This individual injures his right ankle driving for the basket. You can see how quickly this occurs. Classic mechanism, severe lateral ankle sprain. He's not very happy because no foul was called. If you look at the incidence of injuries to the ankle and foot from the NCAA surveillance system, as we would expect, basketball is the number one injury for the ankle. Men's basketball, 26% game-related injuries. Women's basketball second, then women's lacrosse. And when we look at foot injuries, soccer is the greatest number in men's soccer at 4.2%, followed by women's soccer, and then men's and women's basketball. So this will help you understand what type injuries you're going to see, and this makes sense based on the mechanisms and the biomechanics of the sport in basketball and soccer. Physical exam of the ankle is relatively easy. The bones are very superficial, so you can palpate the ligaments and the bony structures. In these Hoppenfeld diagrams, you can see palpation of the tibiofibular syndesmosis, so a high ankle sprain would have significant pain here. You can palpate the dome of the talus, seen in the upper right. So if there's an osteochondral fracture, they might be a little more sore there. However, Xrays or MRI scan is necessary for talar injuries. The anterior drawer sign is done, as shown in the lower left, to evaluate an intact anterior talofibular ligament. In neutral flexion, if there's a severe ankle sprain and the anterior talofibular ligament and calcaneofibular ligament are injured, you would have a positive anterior drawer. In plantar flexion, as shown in this, an anterior drawer positive would indicate injury to the anterior talofibular ligament. Grab the heel, as shown on the right. Stabilize the tibia. I like examining ankles with the patient seated and their knee flexed to 90 degrees. This is an exam under anesthesia of a grossly unstable right ankle. You can see the superficial branches of the peroneal nerve, called the intermediate dorsal cutaneous nerve. So she's asleep. A positive anterior drawer in plantar flexion, examining the anterior talofibular ligament. So really the only thing holding her ankle together is the skin, her chronic recurrent instability, and then you can see the talar tilt here. So the ligaments are absent. She is going to have a brostrum lateral ankle reconstruction. We try to avoid that superficial branch of the peroneal nerve at the time of surgery or an arthroscopy. That's the number one complication after an ankle arthroscopy. So positive anterior drawer, doing it in plantar flexion, but is also grossly positive in neutral flexion. You can see how it's a little less obvious in neutral flexion, the clinical talar tilt, but you can see it in neutral flexion. The tibiofibular ligament is a dense fiber structure that maintains the ankle mortise. We see a lot more high ankle sprains, particularly in offensive linemen. Typically that's a dorsiflexion injury where the anterior aspect of the talus jams up against the anterior tibia and spreads the mortise, spreads the fibula away from the tibia. Prolonged morbidity takes a lot longer to get over, occurs in eversion with the foot dorsiflexed. 1 millimeter lateral shift of the talus within the mortise reduces contact area 42%. We do stress views in these severe high ankle sprains to assess the mortise and make sure there's no instability that would require stabilization. The medial deltoid is superficial and deep components, functions as a single structure, and the primary resistance is to eversion. Less common to have a deltoid medial ankle sprain, but it does occur in eversion. Anatomically, the superficial deltoid fans out from the medial malleolus to insert on the talus posterior, calcaneus medial, and navicular anteriorly. Then the deep deltoid ligament inserts on the neck of the talus, posterior fibers on the medial tubercle of the talus. Physical exam of the foot and ankle. Again, the patient is seated. Dorsiflexion eversion, testing the syndesmosis. If the syndesmosis is unstable, that will spread the fibula from the tibia. Palpation laterally, lateral ligaments, anterior talofibular, posterior calcaneofibular. Palpate the syndesmosis, and then do your reproduction of the mechanism injury eversion. This is where the superficial peroneal nerve sensory branches start from. There sometimes will be a little fascial defect up there, and there's where that nerve supplies sensation, dorsal aspect of the foot. So make sure you always do a neurovascular check, particularly with knee injuries, but also with ankle injuries. If there's a problem with a Morton's neuroma, patients will have pain when you do that push test. Maisonneuve fracture, unstable mortise. Don't miss this injury. If it is missed, as seen in these X-rays, the patient decided not to have surgery done despite making the diagnosis and suggesting surgery. 3 months after her injury, she has a very arthritic ankle and a fibular non-union, which is a very difficult situation. And you can see here in this middle X-ray the significant mortise widening. Sometimes it's not that obvious, but basically the mechanism of injury was through the deltoid, up through the syndesmosis, and exited at this fibular fracture. This is the way the mechanism of injury typically is. Ankle eversion. Foot oftentimes is stuck on the ground, and then the forces go as shown all the way up to exit here. On occasion, you'll have someone that has grass in the medial aspect of their shoe, as shown here. So this again tells us what this mechanism of injury is. It's a pronation external injury of the ankle, as shown here. So the tibia is internally rotating, the ankle, talus in particular, is everting, with the foot in significant pronation and basically stuck on the ground. This is something you don't want to miss. This one again is obvious, but if you do have a syndesmotic injury with or without a fibular fracture, you want to do stress views in external rotation and eversion. You can see this is the stress view that opens it up even more. So have your lead gloves on, grab the calcaneus, and do a reproduction of the mechanism of injury, which is external rotation inversion for a syndesmotic injury. What do we do to treat these? We stabilize the mortise, as shown on the left. So this can be done with 1 or 2 screws. The fibula will heal if we stabilize the mortise, again like a drawer going into a chest of drawers. The X-ray on the right shows a chronic repetitive stress of high ankle sprains with ectopic bone coming off the tibia, which is in an offensive lineman. This is something that we observe. His mortise was stable. We don't do anything to take these out. This is a chronic repetitive stress injury of repetitive stress going into dorsiflexion. This is an example of a fibula fracture. Here, an unstable medial mortise undergoing stabilization of that mortise and exam under anesthesia. Again, this is a non-treated Maisonneuve fracture, rapid progression of degenerative joint disease, and a non-union of the fibula. This is something you never want to miss, so make sure you do stress views, understand the mechanism of injury, and make the diagnosis. How do I treat ankle sprains? This is an air cast. You can see how the ecchymosis and swelling is distributed when you get the air cast on very early. If you can control the swelling, the patient returns much more quickly to sport or regular activities. The air cast is a good one to treat lateral ankle sprains. High ankle sprains oftentimes need a boot and take longer to get over. High ankle sprains take 6 to 8 weeks. Lateral ankle sprains can be braced and taped and get back more quickly if the swelling is controlled. Treatment of ankle sprains: control the swelling, brace appropriately. There are a lot of different types of braces. Sometimes they need to be sport specific. Wear the brace and or tape acutely and during that entire season. We work on proprioception, not really strength, but the ankle eversion and ability to know where the ankle is in space. Work on core. The main problem or reason that a recurrent sprain occurs is there's inadequate rehabilitation from the initial sprain. Are ankle sprains preventable? Seems like a pretty simple question. When we look at Dr. Barr's work, Can We Prevent Ankle Sprains in Evidence-Based Sports Medicine? This simple question is really unknown by evidence-based studies. It's not proven, but we can lessen the severity maybe. Any study needs to be assessed critically. There are some large-scale randomized trials. A prior history of ankle sprain is the main reason for a recurrent sprain. You have to look at the unit of analysis. Is it ankles, which would be 2, or is it players, which would be 1? And this is from Barr's book, The Evidence-Based Medicine. They looked through 5 years and found these studies that could be compared. Retrospective cohort, randomized control, and a prospective, of which there was only one prospective study. And the key messages here are the preventative effects of taping and bracing have been clearly documented, but the evidence is more convincing for players with previous ankle injuries than for healthy athletes. So treat the initial ankle injury correctly, allow them time to return to the sport and brace once the injury occurs. We're not sure if we can prevent ankle sprains, however, with prophylactic bracing. Although there is some indication that braces seem to be more effective in preventing ankle sprains than tape, this has not clearly been documented. The efficacy of wearing high-top shoes is unclear. There's some evidence that balance training reduces the risk of ankle sprains in athletes with previous injury. So work on balance on a pertubated platform so that the athlete can regain that brain to ankle foot control. This is the example of the superficial peroneal cutaneous branches. This is called the intermediate dorsal cutaneous nerve. That is a branch from the superficial peroneal nerve. Sometimes we'll see a little fascial defect up here, and patients will have a positive Tinel's there, so look out for that. Sometimes in baseball athletes or runners, they might have a localized muscle herniation, and then the nerve will get irritated there. At the time of ankle arthroscopy or open surgery, we want to mark and make sure we can see that nerve, which we can see relatively often, very superficial. These are the veins, obviously, and this is the nerve. So when we do ankle arthroscopy, we make vertical incisions and just go through the skin and try to avoid that nerve. That's the number one complication of ankle arthroscopy, is injury to this intermediate dorsal cutaneous nerve. And then this also branches into the medial dorsal cutaneous nerve that we don't see in this ankle. This was her exam under anesthesia, looking at that sensory branches, and then you can see the veins. So here are the veins. We don't have the tourniquet up yet, and then that's that superficial cutaneous nerve that we want to avoid at the time of surgery. This textbook drawing from Per Renstrom shows the orientation of the anterior talofibular ligament and calcaneofibular ligament in neutral flexion and plantar flexion. In plantar flexion, the ATF assumes a course parallel to the axis of the tibia and the fibula, as shown on the right. The modified Brostrom technique, we trim the injured ligaments, shorten and reattach the attenuated ATF and CF ligaments, leaving the peroneal tendons intact and in their sheath. These other procedures that are peroneal brevis rerouting procedures have been done in the past. The subtalar joint sometimes will be overconstrained. This shows the Christman-Snook modified Elmsley, Peroneus brevis split, and the rerouting through the fibula and calcaneus. Lateral ankle pain I think of as a differential diagnosis, most commonly sprain of the anterior tibiofibular ligament and or involvement of the calcaneofibular ligament. Other diagnoses are sinus tarsi syndrome, injury to the subtalar joint, fracture, arthritis of the subtalar joint, cuboid subluxation seen in dancers most commonly, and peroneal dysfunction, peroneal tendon instability, or a split of the peroneal tendon. Think about involvement of the peroneal tendons if the ankle sprain does not improve with time. Anatomically, you've seen where the ligaments attach to the lateral malleolus here, posterior calcaneofibular ligament here. The cuboid, which can be subluxed in some occasions with dancers, typically a plantar flexion injury, but also think about palpating the talus, and laterally here, as well as the Peroneus brevis insertion onto the base of the fifth metatarsal. To examine the subtalar joint, I like to stabilize the tibia and then rock the calcaneus back and forth, and you can palpate the talus as you're doing that. There can be some involvement of the midfoot, Lisfranc injuries, so also rotate the midfoot. Palpate the base of the fifth metatarsal where the Peroneus brevis inserts, and you can palpate the peroneal tendons behind the lateral malleolus. Also, don't forget the posterior tibialis tendon as it attaches, inserts into the navicular, and palpate the bones about the midfoot if you're concerned about a midfoot injury. Palpating now the navicular, which we think about with medial pain, possibly a navicular stress fracture. There are a lot of osses about the foot and ankle. These can be confused for being a fracture, like an avulsion fracture, but these are sesamoid bones. This diagram from Roger Mann's book and Keats shows the different names of these. Os Vesalianum is a ossicle at the base of the fifth metatarsal that can be confused for an avulsion fracture. This is actually an os Vesalianum in a basketball player. So see the separation there? This is not a Jones fracture, which would occur in this area. This is a os that the peroneal brevis was tugging on, and if you think about the sport of basketball, a lot of stop, cut, change direction. So this is a os that has been pulled off, and the treatment for this is excision of this little piece. Don't do anything with the Peroneus longus or brevis. Usually it will be connected very well. The brevis will be connected here, so you just shell out that. If there is significant weakness at the attachment of the Peroneus brevis, this can be rerouted through the bone and reattached. This is an os peroneum, so it's running in the peroneal tendon sheath, and you can see it right here. So different ossicles about the foot and ankle that aren't fractures but can be problematic depending on the sport. There can be a painful os peroneum. This is when an MRI scan may be helpful. As shown by the arrow, this white in the tendon sheath and the bone indicates a painful os peroneum. Seen on the lateral view, you can see the peroneal tendons coming down to insert, and that increased signal indicating a symptomatic os that may require removal surgically. Think about peroneal tendon involvement if the ankle sprain isn't getting better. The pain oftentimes is a little bit higher back behind the fibula, way in this area, and not directly over the lateral ligaments. Assess peroneal function acutely. The patient can evert their foot and palpate the peroneal tendons. This shows the different sheaths covering the peroneal tendons. So this is a palpation of the peroneal longus and brevis, and ask the patient to evert and palpate the peroneal tendons, both the peroneus longus and brevis. Assess for instability. This is an example of a peroneal tendon instability. This is a high school baseball football player who was having more trouble in baseball running bases. He had repeated inversion ankle sprains, which he may have had, but really his diagnosis was peroneal tendon instability. Ask the patient to demonstrate what their problem is. So he is just rolling his foot around, inverting, everting, plantar flex. You can see he's putting his peroneal tendons back where they came from. So that pops forward and then it reduces. Pops forward, then it reduces. He required a fibular deepening procedure and stabilization of these peroneal tendons. He did very well post-op and really didn't have lateral ankle instability. Ask the patient to demonstrate what their problem is, and they can usually give you the diagnosis. So in that ankle sprain that doesn't get better, you might consider doing an MRI scan. Certainly doesn't need to be done with your garden variety lateral ankle sprain, but if it doesn't get better, think about doing that. This is the Peroneus longus as it comes down, and there can be a split in the Peroneus longus tendon that may require surgical intervention. The foot and ankle experts, some do explore this, others think that it will get better with conservative management. But think about a Peroneus longus injury if the ankle sprain doesn't get better, and that would be something to image down the road. This is a case of an 18-year-old female gymnast. She injured her right ankle, landed awkwardly, doing a back tuck, immediate pain and swelling. Here are her initial X-rays. So get an AP mortis lateral view. Don't really see much on the lateral view. You can see a osteochondral injury to the talus laterally in this view that you can't see very well on this, as well on this view. And this is her comparison view here. So this is an acute talus fracture, not osteochondritis dissecans. Stress tests. Here's her involved ankle, non-involved ankle. So she did have a lateral ankle sprain. The decision needed to be made because we had to go in and look at that piece and probably remove the piece, whether or not she needed a lateral ankle reconstruction, which she did not. So she really didn't have any clinical evidence by X-ray of significant instability. This is her MRI scan that showed this displaced fracture here and the bone edema of the talus, indicating an acute injury, not anything like an OCD. At the time of surgery, unfortunately, these pieces are usually small and have very little cancellous bone, so it's difficult to fix them. And when there's one piece, there are usually several pieces. So this is her arthroscopy where I removed those pieces, smoothed things up, did not do a lateral ankle reconstruction, and she did fine post-op. This is after I've gotten the pieces out down here. And these are these small pieces that unfortunately could not be fixed. This is a 14-year-old soccer athlete, left ankle injury. She had plain films and edema was noted on her MRI scan. So these are her plain films. Don't really see much. Isn't as obvious as that gymnast that I just showed. But this is what her talus looks like. So you can see the intense increase in activity on T2, indicating significant bone marrow edema. And you see this little non-displaced fracture right here, best seen on the lateral MR. And now 1 month later, you can see her osteochondral injury that we couldn't see before. So it is Of note that some ankle sprains, if they're more severe or they have more talar tenderness, you may want to consider an MRI scan, or if they don't get better. So I would have immobilized her, kept her non-weight bearing, and bone edema takes a while to get over. She ended up doing well with non-operative treatment. This is a fracture in a 45-year-old golfer who was tossed out of the golf cart, landed awkwardly. This was missed. So when these are missed, these are bad injuries because, again, the ankle is a structure that is like a mortise. So you have the chest of drawers here and you have the drawer. So if this drawer is unstable, then we will develop osteoarthritis, unfortunately. So osteochondral talar lesions, 55 years ago, Burnt and Hardy described this in the Journal of Bone and Joint Surgery. Osteochondritis dissecans of the talus is more common in males than females, 3-to-1, and is more common medial aspect of the talus than lateral, 2-to-1. The etiologies, multifactorial, trauma, vascular, repetitive loading. So this is an example of an X-ray of an OCD. You can see how that looks much different than an acute talar injury where there is no displacement, more of a chronic repetitive problem, and a chronic OCD that still is treated arthroscopically with microfracture and a long time of immobilization. These take a long time to get over. This is a left ankle injury in a football athlete. Watch as this running back goes up over, comes down, and he goes to try to get up. It's good to make sure you tell your coaches not to pull the players up. So he gets up on his own, starts hopping around, doesn't put any weight on his left lower extremity, a sign that there's something significantly wrong. And if you watch it again, it's just right out of the screen. So he goes up, comes down, all of his weight is on his left ankle, he's spinning, AstroTurf makes his foot not move, spins and comes down and has a severe ankle injury. You don't know, get them off the field with their shoe on, gently take the shoe off, have somebody stabilize them proximally, try not to hurt them. It's a little easier to get them off the field with the shoe on and then get them to a point where you can take their sock off and then examine them on the sideline. This is after we've gently taken his shoe off. We have him on the table lying down. Take his sock off, try to do as little movement as you need to, and you can see there's obvious deformity here. He has a subtalar dislocation. And this was 5 minutes after getting him from the field to the training room, and look at the significant swelling. So applying axial traction does no harm. He's still not reduced yet. So a lateral subtalar dislocation. Do a neurovascular check. Asked him to move his toes around. I like doing reductions in sweaty people where there's wet with gloves. So all I'm doing is applying axial traction. You'll see it pop back into place. No anesthesia was required. If you can do it right quick after the injury, then you should be able to do it just with talking to the patient about what's going to happen and putting it back into place. Understanding the anatomy of the ankle, the mechanisms of injury, will make it much easier for you to make the correct diagnosis in ankle injuries. There are some unusual diagnoses out there. Don't let anybody trip you up. Thank you for your attention.